Thanks very much for inviting me. I'll do the presentation in 3 parts. I'll run through pretty fast about GAVI and how we work, COVAX itself, and then Philip challenged me to say, well, you're doing all this, what else do you need? Where are some areas where you've noticed some gaps? So we've done a bit of thinking and we'd like to suggest a few ideas to you. So GAVI itself, the Global Alliance for Vaccines and Immunisation, it was created in 2020 out of Davos, saving children's lives, protecting people's health, equitable use of vaccines. Now, it's actually the model which is quite interesting, and the reason why. And the reason why, huge population growth, 84% reduction in common vaccine preventable diseases. So we knew that vaccines made a huge difference, but they were making a difference in high-income countries where nearly all of the vaccines were, and a breadth of protection, a number of different vaccines offered from childhood right through to some pandemic diseases. And the point of GAVI was to say we can bring in some financing, focus on low-income countries, and at least have an equitable situation, same vaccines available, good, strong primary healthcare systems coming in as a result. It's an alliance, it's a public-private partnership. You can see here the partners. In the interest of time, I won't read them all out, but very close working with WHO and with UNICEF. WHO sets the policy. It's also the regulator. It also has offices in the countries. We don't. We work out of Geneva and Washington. And then UNICEF is our massive delivery engine, also with officers and staff in the countries and expertise there. We raise funds from donor governments and foundations, and then we use the funds to buy vaccines and support program. So these are the vaccines that we've introduced over the 20+ years, 21 years. And you can see there that we've been steadily going for breadth of protection and a life course approach. So the 3 big areas we work in: health system strengthening, vaccines don't deliver themselves, the vaccine support, and the technical assistance. And that helps because vaccines get to 80–90% of the population, around 90% get DTP1, which is the first and most prevalent vaccine. You can start building other health services there, or you can complement existing health services. It helps. You can check in on new mothers. You can provide other health checks in terms of deworming or malaria bed nets and things like that. So it helps very much contribute to primary health care. So what we do, we get our 5 billion or our 7 billion for a program. We have programmatic cycles of approximately 5 years, and we go to countries and say, and we work with them to see which vaccines that they need, and we work to get ready to introduce. We aggregate the demand and we go to the manufacturers with the funds, with the aggregated demand, and negotiate very hard on price. And our model is that no one gets a free ride. We work with countries and we say, okay, you put in this much, we'll put in this much, and then over time we expect that countries will start funding their own immunisation programs and then transition out of the support. And then we're about to start, or we have started, our new cycle, our new program, and we're focusing very much in this one on 0 dose. 0 dose is the children who have no access to immunisation at all. I talked before about 90% of DTP. That leaves 10%, 8% of children who have nothing for various reasons. And there's an absolute correlation between that and children who are in the most vulnerable situations, or poverty, conflict areas, fragile areas, and so on. So that's our next program. But I'm mostly here to talk about COVAX. So COVAX was born very, very fast. I was part of it all. Last January, we were getting quite worried. February, we were getting very worried. And we could see by the end of February and early March that we would face a situation very quickly where if there were vaccines that were able to be made, high-income countries had the funds and the ability and had the manufacturing sites by and large, and would get access very fast to as many vaccines as they could, and that it would almost certainly be a limited supply and a global emergency. And so we got together with CEPI, the Coalition for Epidemic Preparedness, who work with vaccine developers and manufacturers. So they're at one end of the chain. We come in with the funding piece, and also the supply and work on the delivery side of things, the contractual arrangements with manufacturers and so on, and many other bits and pieces. WHO looks at the allocation policy and the regulatory piece, and UNICEF on the delivery piece. So we became part of a very fast group, and we were meeting, from early in the morning till midnight, 2 a.m. in an emergency situation. And that it hasn't really eased off. My colleagues this morning, we were talking, they'd finished work at 2 this morning on a whole lot of stuff that was happening. So we've been for a year and a half, and with thousands of people around the world, academics, governments, government health services, government policymakers, civil society organizations, vaccine developers. We've all been working around the clock on this, and we've got a long way to go yet. Now, this is part of a four-pronged approach which came together, and that was called the ACTA, which is Access to COVID Tools Acceleration. And so there's a vaccines arm, there's a therapeutics arm, a diagnostics arm, and health system strengthening. And in fact, that's where we're also developing a manufacturing area. So we each have different roles in this. This sets out the roles that I went through earlier. And the aims were ending the acute phase of the pandemic, delivering 2 billion doses. I'll come back to that in a minute. To get the largest portfolio of vaccine candidates as possible. You'll be well aware, many of you, that you can start off, we were at a point where there were sort of around 100 candidates at one point, and they drop off as the phases go on, as time goes on, and different things like safety, effectiveness, and so on are tested out. And then we wanted, the big piece was the equity piece, very much wanted to focus on low-income countries and deliver the vaccines quickly. So they were the objectives. And what could we do together? Pooled demand and financing. In fact, it was quite astonishing. We had just raised around, 5, 6, 7 billion for GAVI Mark V, which was our 5th program cycle. And we were back within a very short time to donors and funders saying, please, can you give us funds for COVAX, for vaccines, primarily in low-income countries, although COVAX has 2 parts. We also buying vaccines for middle-income and some high-income countries as well, but that's all self-financing. That doesn't come from the donated funds. So we went out to the world and we raised around $8 billion, I think. And more since then. I think we're up to sort of close to 10 billion now. We had another run at it. So we had funds, and the funding thing is very critical here, because high income countries could immediately go to manufacturers. They had the purchasing power. They have enough in terms of their credit rating, enough in terms of their reserve banks and so on. Low income countries and middle income countries primarily had to look at loans. And if you're looking at loans, you're looking at debt for future generations. Our accountability measures were that we couldn't make or sign contracts until we had the funds. And so that made us in a slower situation than high income countries that could immediately sign the checks, sign the financial contracts. Nevertheless, we were able to make contracts and get something around and go to manufacturers with the aggregated demand. Of course, it was a very competitive and still is a very competitive environment. We invited everyone into the fund because we wanted it to be, all into the COVAX facility. We wanted it to be a global solidarity piece. If you're trying to deal with a pandemic, as many of you know, you've got to get it everywhere and you've got to get it in a very considered way. Otherwise, we're talking about variants and we're facing that now. More than 195, I think now, participants. We say participants because some of the members of the facility are not recognised as countries by others, and so we use the term participants. That's around 92 low-income participants as defined by the World Bank, and then others. So we had a breadth of vaccines that we were getting access to, and a lot of countries in the mix. 9.8 billion raised overall. Of all of the candidates which have gotten through, many of which you'll know the names for, we have 11 vaccine candidates. We wait until WHO or one of the stringent regulatory authorities approves before we will actually do the contracts. 1.9 billion doses for delivery, and 91% of COVAX participants have received the first shipment. However, not enough, and I'll quickly go into that now. 237 million doses actually delivered. And there's a few reasons for that. And in fact, we just released our Q4 supply forecast today. And that shows that in the next quarter, in Q4, there'll be 850 million doses going out the door, which is good. And that will bring up to 1.4 billion. Remembering that in the initial phase of this, COVAX offered to support for around 20%. And the 20% came from a calculation that the countries did on healthcare workers, vulnerable people, and the aged. So all of that together is how we got the figures and the numbers that we were aiming for in terms of getting close to 2 billion doses. And that's sort of thinking through a 2-dose regime. Despite having, hopefully by the end of the year, 1.4 billion doses, hopefully more, out the door, that's 500 million under where we thought we would be. And the reasons for that, we've been hit pretty badly by export controls. We also don't have a lot of transparency on the manufacturers' production schedules. So when manufacturers come to us and say, you know, we've got an issue in this particular plant or with this particular cycle and so on, probably they do, but somehow bilateral contracts are being fulfilled at great rates in high income countries, 50, 60, 70%, and they're not being fulfilled through COVAX for lower income countries. And that's a real challenge for us. We're pretty disappointed. And we've just written to manufacturers to say, look, we want to be first in the queue from now on. And we've written to governments and said, we want you to start, you know, foregoing your place in the queue for us. There's plenty there. But you know, we would really like you to also donate or swap your slot in the queue or donate with as little earmarking as possible as we try to bring the numbers up. And we'll have another billion or so in the first quarter next year. So this is, I spoke of dose donations. This is just a really quick look at those. We get a bit challenged when the donations come earmarked, and you know, no surprises why they're earmarked. There are some countries who have deep and long-standing relationships with other countries and they prefer to see their doses go there. That's a real challenge for us. Absorptive capacity of countries is also a challenge. We're often going into quite weak health systems, whereas in the past we've been looking at a lot of our work has been with young children. Suddenly we're having to do healthcare workers the age, so governments are having to really expand immunisation programs in some challenging circumstances. And I'll come back to that too. So this is pretty much my last slide. And what I wanted to do was, Philip said to me, you know, there's going to be a bunch of academics. We're all thinking about the research. We all want to help. You know, where are some areas that have come up? And so there's a few different things. So one is around vaccine policy research, which is fit for purpose for LMICs, lower middle income countries. A lot of the efficacy data, the efficacy trials and so on are coming from high income countries. And so it's, you know, and policy is being made around that. Allocation thinking is being made around that. Age group cohorts, the way that you get to populations is being made around that kind of research and thinking. And if you then start going into lower income countries, you have a very different context. You have context with urban sprawl, with deep poverty, with very large numbers of HIV positive populations and so on. So you have a lot of context that's missing and a lot of research that's missing there that is skewing the rollout and the policy thinking around the rollout. This is, so the effectiveness data and the context around that is something that we would like to, you know, more contextual and more appropriate information on. It's also an issue with variants of concern. Variants of concern, you know, hit some countries in a different way to other countries. And honestly, the vaccine effectiveness data, often we're getting that when a variant of concern hits a high income country and the research is done. So if it starts in low income areas, there's pieces missing there. So, you know, are there ways to use diagnostics and vaccines more effectively in a working relationship together in a low income country context? So these are the sorts of pieces of information, subpopulations of special interest. If there's more research and data on subpopulations of special interest, it is going to be easier to work with communities who face those particular contexts because you have data and policy thinking recommendations which are applicable to them. The second area is around the political attention. You know, very early on in this, I was talking to some colleagues and I remember saying, you know, and they were all like, oh, you know, we don't know if we're going to get vaccines. We're sort of doing this and that. We were designing and developing and building this whole piece. There's hundreds of people involved around the world just in this particular bit. And they're working together with thousands of other people in the research area, technical area, and the fundraising area. And I'd always thought that the vaccine piece was probably solvable, being an optimist. Operations, you know, plenty of models there to draw from, plenty of systems, not good enough, but at least they're there. But I had always thought the politics is going to be the tricky bit there. And it really has been, you know, there really are a set of barriers and blockages to think through here. And it would be good to have some thoughtful analysis and recommendations coming out of this. And I'll give you an example. The high income countries put their hands in their pocket and immediately, you know, put $9 billion on the table. They talked about global solidarity. Research data was shared all around the world. The Chinese, you know, sort of put on in the public domain everything that was needed so that vaccine developers could jump in really fast. So really great examples of global solidarity there. But then on the other side, we've had export controls put on. We've had high-income countries talking about third doses. We have high-income countries who are facing domestic situations which are very difficult for them because people don't want to be in lockdown. So they're having to try and put health policy and juggle that off against economic policy and you know, which well-being is the most important and things like that. But we are getting domestic scenarios, you know, much more attention around the domestic scenario. And the political piece around the global solidarity, we're still seeing quite a lot of, you know, it could be a lot better. So I think the political side of things, And no one wins with this. When India puts an export control down on SII, so I think you're jumping in, so I should finish. I'll be really fast. How about one more minute? So when you get an export control, when we buy from a middle income country and you get an export control there, like South Africa earlier this week or India, they have a big problem that they need to solve. But that stops us getting doses for the rest of Africa, or the AU getting their doses, and so on. And then the last thing is a multidisciplinary approach. So we have seen, global health security or security issues. We have seen the crossover with economic issues. There's the crossover with education issues in terms of lockdown. And so there are many interdisciplinary areas that it would be great to explore. So that's it from me.
Thank you. Thanks, Susan. That was really, really helpful in terms of it. And obviously these are real challenges. I suppose one question just for you is that clearly, I think the view from earlier speakers such as Mark Schitt and Andy Pollard have been that it is a kind of gone from a long run sort of tackling COVID will be along with us, or COVID will be with us for a long time. And so as COVAX started to think about that it's not just rolling out a vaccine or a double dose to the world, but possibly having to sort of do this regularly over the next few years, and what structures might you put in place to make that possible?
Yeah, that is actually a live discussion before our board at the moment. So we were, happily on our way to strategy number 5 when this hit. We jumped in because it was an emergency. It made sense to try for a global pool and global buying. There were all sorts of advantages to that. And so we do need to think going forward, do we go back to low-income countries only? What do we do in terms of variants? What do we do if, at the moment, we don't have a recommendation from WHO for boosters? So the thinking is happening, and we are looking at different models going forward. But at the same time, there is a look at the whole ACTA, so the diagnostics piece and the therapeutics piece and the health systems piece as well. What does that look like going forward?